Great. So good afternoon. So I'll be talking about regenerative therapy for Peter's anomaly. These are my disclosures. They don't pertain to what I'll be talking about. So Peter's anomaly was initially described in 1906 and is characterized by shallow anterior chambers, corneal central leucoma, and a defect in basal membrane. Often there is synechia between the iris and cornea. There are three main subtypes of Peter's: type 1, which is basically central corneal opacity with iridocorneal adhesions; type 2, which often involves some lenticular problem; and type 3, which is Peter's plus, where there's often some systemic associations. And mutations in PAX6, PIDX2, FOXC1, and C1, P1B1 have all been implicated. And approximately 70% of cases are bilateral, and it's more likely associated with systemic malformations, but most are actually sporadic. If you look at the treatment for Peter's anomaly, most of it is conservative for mild opacities, inducing mydriasis and basically occlusion therapy. Surgical options include large peripheral iridectomies or even penetrating keratoplasty, and most people will consider doing this in the first year of life to avoid amblyopia. But the success rates vary hugely dependently whether you're talking about type 1 or basically type 2 Peter's anomaly. If you look at these two charts on this side, on the left-hand side, these are two of the largest series published in the literature with respect to outcomes from Peter's anomaly versus unilateral disease and bilateral disease. And this is the surgical treatment. We will see most children do not obtain better than between 2100 and 2015 visual acuity. In fact, the median logMAR visual acuity is about 2.5 logMAR postoperatively. If you look at graph survival over here on the right-hand side, this is a publication from Wills. You'll see the children with type 1 visual acuity, type 1 Peters do certainly better than patients than children with type 2. However, if you look at the visual acuity results, none of the children actually attain better than 20/40 visual acuity, even though the graphs were actually clear. And we know this because, of course, you have other issues with corneal transplantation in children. So what is regenerative therapy? So regenerative therapy is the process of replacing, engineering, or regenerating human cells or tissues and organs to restore and establish normal function. And the idea is, or the concept, is stimulating the body's own repair mechanism to functionally heal a previously irreparable tissue or organ. So if we think about the corneal endothelium, we have to also understand that we know from our clinical literature that the corneal endothelial cells can migrate. Migration is going to occur from the corneal donor onto donor decimal membrane following full thickness peritoneal keratoplasty. We know that the outcomes from patients having endothelial keratoplasty, when you compare bullous keratopathy versus Fuchs endothelial corneal dystrophy, are different because the peripheral corneal endothelium is different between the two situations. We know if you look at sex mismatch graphs and you look at the donor retrievals, there is a mixture on the recipient donor cornea from the donor and recipient. And of course, Garrett Mellers described a technique of doing primary dysmetrorexis when he looked at the outcomes of patients undergoing DMEX surgery in patients with Fuchs who had peripheral migration of their corneal transplantation. So a few years ago, we wanted to study this in an ex vivo culture model. This is what we basically did. We got ex vivo donor corneas, we scratched one surface over here, we peeled the surface like we do with a dysmetrorexis, and we wanted to study the age of the effect on donor migration and also the induction of basically ROCK inhibitors. So we used 2 human donor pairs. These are the kind of results that you can get. So this is 3 days, this is 9 days, this is 14 days. You can see the scratch one on the left-hand side, the peeled one on the right-hand side over here. These are donor matched, so it's the same donor, and in one we put ROCK inhibitor, and one we didn't put ROCK inhibitor. And what we wanted to calculate was the maximal endothelial migration within weeks and endothelial migration as a percentage basically per day. These are the results basically that we were able to find, and the first thing we found is that the presence of the decimate membrane definitely increases the speed of the endothelial migration, and this was irrespective of whether you have a Rho kinase inhibitor present or you have a Rho kinase inhibitor not present. However, if you look at the results of in the presence of decimate membrane, you will see that there is definitely an age effect. So the younger donors, you had an increased bit of cell migration, but you can see as you get older, you get a reduction basically in your cell migration as you'd expect as the donor tissue gets older. However, if you look at this graph over here, this is the one with the ROCK inhibitor. By adding a ROCK inhibitor, what you can do is you can increase the endothelial migration speed from almost 10% in a 70-year-old donor up to about 80%. So the addition of ROCK inhibitor increases the speed of endothelial migration. In the peel group, we didn't get any recovery over 3 weeks, but this may be a limitation of our technique for doing this study. We went on to study this using an ex vivo technique. So basically, this was studied in rabbits where we compared scraping versus peeling versus transplantation of a human decimate membrane without any endothelial cells after we'd done a peeling technique where we'd removed the endothelium and decimate membrane. And these are the results we'll be able to show. And what we're able to show is if you peel away the decimate membrane endothelium, you get a massive amount of edema at 10 days, which goes down by 30 days. If you scrape, so you leave the decimate membrane intact, the endothelial cells can migrate. Of course, this is a rabbit, so the endothelial cells can migrate across the surface by 12 days. If we peel and we transplant a human decimate membrane without any endothelial cells, we can replicate exactly the same results as if we basically left the decimate membrane intact. So this gave us the idea of basically a new therapy for children with regenerative therapy and also new therapy for adults. What we learned was that age has a significant effect on endothelial migration. The presence of decimase membrane is important, and ROCK inhibitor can negate the effect of age. In adults, what we currently do is in Fuchs, we strip away the central guttata and we transplant a pure decimase membrane, but in a younger age group, we can maintain a decimase membrane and allow endothelial migration. And this is what we're going to show you on some children. So this is the first child that we basically did. The child initially presented at 3 months old, typical type 1 pedis on the UBM. You can see the iris adhesions on the surface. So the A scan showed a normal axial length, intraocular pressure was normal, the child's visual acuity was 29/60 in the right eye, 20/30 in the left eye. The child underwent mid-tracheal drop therapy and occlusion therapy, and then unfortunately we lost the child to follow-up for about 18 months. There was no change in the visual acuity. They went to seek 2 or 3 doctors who asked about doing PK and adhesion lysis or endothelial keratoplasty and adhesion lysis. And because of what we learned with our basically endothelial dysfunction, I offered the child to do selective endothelial removal and adhesion lysis. So this is the surgery. So what we do is we have an AC maintainer on the left-hand side. This is an instrument made by Asicoform, which has a small silicone tip on the surface. And what we do is we release the adhesions underneath the central opacity. I'm staining now with trypan blue to show you that basically I've removed away all the endothelial cells in the central area, so you can see the endothelial margin around the surface. And then what you'll see is that we basically put some sutures in. I put an air bubble just to show you that there's no stripping away the decimase membrane, so it's just purely selective endothelial removal, not decimase stripping. This is a clip from basically from the surgery, from the publication, so it shows you the removal of decimase membrane, of the removal of endothelial cells with an intact decimase membrane. 6 weeks later, I go back to basically remove the stitches. You can see the pupil is dilating more, the opacity has gone down a little bit. I inject the trypan blue into the anterior chamber, and you can see over here that the endothelial cells have basically migrated across the surface. So we followed this child up. So this is basically 1 week, this is 3 months, this is 6 months, and this is 9 months. The child's visual acuity is now 20/30. Corrected, of course, with a corneal thickness of 465. So the child's refraction now is about, basically, he was +4 minus 175 in the left eye, +6.5 minus 350. I've just seen the child recently. He's 20/30 now in that right eye, +3.5 minus 350, maintaining visual at 20/30. No steroids, just basically undergoing amblyopia therapy, and of course we monitor for the glaucoma. These are another 2 cases, so this is case 2, case 3, 930 corneal thickness, 740 on the 2 cases. This is at 3 months post-op, 460 microns in the center, 540 in the left eye. So in conclusion, Peters normally is a common cause of congenital corneal blindness. Surgical outcomes are variable and better with type 1 than type 2. However, graft survival does not equate to good visual acuity, and many children require repeat grafts due to graft failure, rejection, and associated complications like cataract and glaucoma. Our ex vivo migration work gave us the idea to try a new minimally invasive therapy for type 1 Peters. Our first in children cases have been encouraging. We've done 4 cases now, and it's been replicated in USA and also in India. Patient selection is important, and the patient still requires amblyopia therapy and regular intraocular pressure. This is the first child that had the therapy now. She's now 4 years old and is able to see 20/30 without any medication. Thank you for your attention.